So a lot of what happens with the body is changes in pH. Your blood is naturally sitting at 7.35, goes to 7.45 when you start to have issues. So we are already naturally basic. Yeah, we're naturally basic. It's not 7.7. 7 is perfect pH. We are naturally slightly basic. You go into muscle spasms after 7.45. After 7.25, I believe, is coma. I should remember that, but I don't. Hypoventilation, hyperventilation, and hypoxia can disrupt the acid-base balance to the body, may lead to a rapid deterioration and death. Respiratory and renal system help maintain homeostasis. Homeostasis, we know this is the body's tendency towards stability in the body's internal environment. This is you with no problems, you're not hungover, you are eating your vegetables and took all your vitamins and healthy bowel movements. Homeostasis requires a balance between acids and bases. Fastest way to eliminate excess acid is through the respiratory system. Can be expelled as carbon dioxide from the lungs. Slowing respirations will increase the level of carbon dioxide. Renal system regulates pH by filtering out more hydrogen and retaining bicarbonate when needed, or doing the reverse. Fastest way to eliminate excess hydrogen ions is to create water and carbon dioxide. Hydrogen ion, hydrogen plus charge. Lack of an electron in the hydrogen. Can be expelled as gases from the lungs. Anything that inhibits the respiratory function can lead to acid retention and acidosis. Alkalosis. This can develop from respiratory rate that is too high or volume that is too much. 4 main clinical presentations of acid-base disorder. You have respiratory acidosis, you have respiratory alkalosis, metabolic acidosis, and metabolic alkalosis. Fluctuations in pH due to available bicarbonate result in the metabolic acidosis or alkalosis. Fluctuations in the pH due to respiratory disorder result in respiratory acidosis or alkalosis. Acid-base disorders that are not immediately correctable by the body's buffering system cause the body to initiate a compensatory mechanism to help return the levels to normal. This is a lot, I know. Patient management often involves treating more than one form of acid-base imbalance. So you have the patient's assessment airway evaluation. The importance of carefully assessing the patient's airway and ventilatory status cannot be overemphasized. So quantity of your assessment determines the quality of care. Assessing their patency, make sure it's open. When managing the respiratory problem, first determine, if it's open. If the adult who is responsive is alert and able to speak, complete sentences, normal voice, there is no immediate airway problem. An unresponsive patient has a compromised airway until it's been ruled out. Signs of airway compromise is an unresponsive patient includes snoring. You'll hear them snore. Could be vomited, straining from the mouth, gurgling sounds heard during breathing, secretion of pooling in the patient's mouth indicated by a markedly depressed or absent gag reflex. The gag reflex is a spastic pharyngeal and esophageal reflex that is caused by stimulating the posterior pharynx to prevent foreign bodies from entering the trachea. Absence significantly increases the risk of aspiration. So whenever you get things that shouldn't be in your esophagus all the way to your lungs. An adult who is responsive, alert, and able to speak has no immediate airway or breathing problems. Normal breathing in an adult at rest is characterized by the rate of 12 to 20 breaths per minute. Adequate depths, tidal volume, and regular patterns of inhalation and exhalation. Regular patterns, inhalation, exhalation, clear and equal breath sounds bilaterally. That is both lungs. Changes in the rate and regular should be subtle. So recognizing inadequate breathing. Patient should be assessed by breathing adequacy. Breathing does not necessarily mean adequate breathing. General rule, if you can see or hear a patient breathe, there is a problem. If you can see, I think they misread that one. If you can't see it, An adult who is breathing at a rate of less than 12 breaths per minute or more than 20 breaths per minute must be evaluated for other signs of inadequate ventilation, such as shallow breathing, regular pattern, altered mentation, and adventitious. What is this word? Adventitious. Airway sounds. Abnormal airway sounds, such as agonal breathing. Cyanosis, blue or purple skin in color. It is a clear indicator of a low blood oxygen level. Patients with respiratory distress often compensate with preferential positioning, such as upright, sniffing, tripoding position. So they're going to kind of be like this because they're opening this airway. They're the least amount of effort for air to travel without hitting resistance and friction is what they're shooting for. Semi-Fowler. This is a semi-sitting position. This is what we will put someone up into in the stretcher. We're going to slightly bend it like this so they're reclined just barely, and that will make it easier for them to breathe as opposed to sitting down completely. Potential cause for respiratory distress is trauma, brainstem, insult, noxious oxygen poor environment, renal failure, respiratory muscle impairment, spinal cord injury, central nervous system impairment, and severe infection, sepsis. Multi-organ system body shutdown infection, sepsis. To properly manage the airway, perform the following steps in order. We're going to open the airway. We're going to clear the airway. We are going to assess the airway, and we are going to provide appropriate interventions. Evaluation of a patient with a respiratory complaint includes visual observations, palpations, and auscultation, that is listening with a stethoscope. Visual techniques. At first, use the sight of the patient's position, the tripod position. This is with their elbows out and experiencing orthopnea. Positional dyspnea. So if it's at a certain position they can't breathe, that is orthopnea. Adequate rise and fall, the chest adequate tidal volume. Make sure that both of them are going up and not unequal. Patient gasping for air and air hunger. Skin color moist or clammy, diaphoretic. Nostrils flaring out. Breathing through the pursed lips. COPD people, they'll purse their lips to create a negative pressure to inflate their lungs and alveoli themselves. And they'll typically have a barrel chest with a lot of muscles around the lungs, the chest, not the chest, but like the lungs. You can tell. Any restriction, skin pulling around the ribs during inhalation, intercostal at the suprasternal notch. That's here. And the supraclavicular fossa. Subcostal. Patients using accessory muscles to breathe. Chest wall is moving symmetrically, and asymmetric indicates that airflow into one lung is decreased. Patients taking a series of quick breaths followed by prolonged exhalation. I'm running out of memory. Patients with inadequate ventilation may appear to be working hard breathing, labored breathing, and may involve use of accessory muscles, such as the sternocleidomastoid mastoid neck muscles, chest, pectoralis, abdominal muscles as well. Signs of inadequate ventilation include the following: respiratory rate of fewer than 12 breaths per minute or more than 20 breaths per minute. Irregular rhythms, so a series of deep breaths followed by a period of apnea. Apnea is not breathing. Diminished, absent, noisy, oscillated breath sounds. Abdominal breathing, reduced flow of air out the nose, unequal, inadequate chest expansions. I feel like we're going through the same thing. Retractions. Skin is pale, cyanotic, cool, clammy, mottled. Take note of all these. Staccato, speech patterns. Someone is talking like this at a very staccato rate. When assessing a patient with respiratory distress, consider the possible reduced oxygen levels in external environments. Feel for air movements in the nose and mouth. Observe the chest for symmetry. Note any paradoxical motion, opposite motions of the chest, and assess for pulsus paradoxus. Clinical findings in which systolic blood pressure drops more than 10 millimeters Hg during inhalation. I think I do this. No, my heart rate slows down. some sort of dysrhythmia. May detect changes in pulse quality even though the disappearance of a pulse during inhalation. May detect a change in pulse quality. Yep, that's it. Pulsus paradoxus. Generally seen in patients with conditions that cause an increase in intrathoracic pressure. Decompensating COPD, severe pericardial tamponade, tension pneumothorax, and severe asthma attacks. 3 minutes. Ask questions to determine the evolution of the current problem. So there's onset, sudden, gradual, known as the trigger. Known cause or trigger. Duration, constant or recurrent. Does anything alleviate or exacerbate the problem? Any other symptoms, such as productive cough, color of sputum. You could have brown sputum, green sputum. You could even have pink sputum, but that is a more insidious issue with the pulmonary system. More symptoms such as productive cough, yes. Any intervention attempted before EMS arrival. Has the patient been evaluated by a physician or admitted to a hospital for this condition in the past? So these are all questions we still want to know. Is the patient currently taking any medication? If so, determine the overall compliance by asking, have you been able to take all of your pills as directed? Is there anything that has stopped you from taking your pills as directed? Look at the prescription date and directions to verify your information. Were there any changes to the current prescription, such as new medication, changes in prescribing direction, changed amounts, any risk factors that could cause or exacerbate your conditions, such as alcohol, illicit drug use, or cigarette smoking. Also inadequate diets. Evaluate the protection reflexes of the airway, so you have coughing, sneezing, gagging. A patient whose cough mechanism is suppressed is at serious risk of aspirating foreign material. Sighing is a slow, deep inhalation followed by prolonged exhalation. Periodically hyperinflates the lungs, thereby re-expanding, this is a new word, atelectatic, collapsed alveoli. Your alveoli are like this, they catch oxygen cells, but maybe they could be collapsed. COPD helps us. CPAP helps us. Also BiPAP. Periodically hyperinflates the lungs, thereby re-expanding the atelectae. Yep. Average person sighs about once per minute. Sighs. Interesting. Hiccuping, a sudden inhalation due to spasmodic contraction of the diaphragm cut short by the closure of the glottis, serves no physiological purpose. Persistent hiccups may be clinically significant, like that one Grey's Anatomy episode. Patients with serious injuries or illness may present with changes in respiratory pattern. This table shows abnormal respiratory patterns. We're almost out of memory. Look at them. They're all abnormal. All right, that's what this is. So giant stroked breathing. This is a sign of something specific. We'll come back to this.